By the time the first tremor appears, the moment that brings most people into a neurologist's office for the first time, the biological process responsible for that tremor may already have been developing for 10 to 20 years. And by that same point of initial diagnosis, somewhere between 60 and 80% of the particular neurons responsible for controlling smooth, coordinated movement may already have been lost, 60 to 80% gone before the first symptom was even recognized. This is one of the most important realities about Parkinson's disease that many people never hear during their first appointment. The visible disease, the tremor, the stiffness, the slowed movement, is not where the process begins. It is the point at which the damage finally reaches a threshold the brain can no longer compensate for. Today I am going through every stage of Parkinson's disease, including the stage that occurs before any diagnosis can be made. What the disease is doing inside the brain at every stage, what the person experiences, what their family and caregivers are going through, and what each stage means for the decisions that lie ahead. Here is the number that gives this entire video context. Parkinson's disease is the fastest growing neurological disease in the world. That finding was published in JAMA Neurology in 2018 by researchers examining global Parkinson's disease trends across 5 decades. The number of people living with Parkinson's has more than doubled over the past 25 years. In the United States, roughly 1 million people are currently living with Parkinson's disease. Around 90,000 new diagnoses are made every year, a figure representing a 50% increase compared with estimates made less than a decade ago. Parkinson's disease is not rare. It is widespread. It is increasing, and it remains significantly underrepresented in public health discussions compared with its actual prevalence. Understanding the stages matters not only for people living with Parkinson's, but also for the families and caregivers who will move through those stages beside them. Most people receive their diagnosis without receiving a clear explanation of what progression actually looks like. This video is intended to provide that explanation. Subscribe now and help this channel reach the people who need this information most. One of the most limiting misconceptions about Parkinson's disease is that it is simply a movement disorder, with tremor as its defining characteristic. Tremor is certainly one of the most visible and recognized symptoms, but Parkinson's disease is a neurodegenerative condition that affects much more than movement. It can affect sleep, mood, cognition, digestion, blood pressure regulation, and the sense of smell, often many years before the tremor ever appears. The reason this matters is simple. Many of the earliest warning signs of Parkinson's disease are not movement symptoms, they are non-motor symptoms. Changes in digestion, sleep, emotional regulation, and sensory experience can appear years and sometimes decades before the motor symptoms. If Parkinson's disease is viewed only through the lens of tremor, the opportunity to recognize it early, before most of the relevant neurons have been lost, is repeatedly missed. Here is what you should understand by the end of this video: the 5 clinical stages of Parkinson's disease. What is happening in the brain during each stage, what the person experiences, and what the family around them is going through. I am also going to explain the stage that comes before all 5, the prodromal phase, where the disease is developing before a diagnosis is possible. If you or someone close to you has received a Parkinson's diagnosis, this framework can help you understand what you are facing and what may come next honestly and clearly, without the uncertainty that many initial appointments leave behind. If you are watching for a parent, a partner, or someone whose diagnosis you are trying to understand, this video can give you the language and framework needed to become a more informed presence in their care. I also want to be direct about something that this channel discusses extensively in other videos. Approximately 50 to 80% of people with Parkinson's disease may develop dementia during the course of their illness. We will discuss this specifically in the later stages because families deserve to understand this possible trajectory before they encounter it without preparation. Let us begin before stage 1. Let us begin where the disease actually starts, before the stages. Just 2 minutes on the biology, because understanding the mechanism makes everything that follows much easier to understand. Parkinson's disease results from the loss of neurons in a small region deep within the brain called the substantia nigra. The name means black substance in Latin because, in a healthy brain, this region appears visibly dark due to a neuromelanin pigment produced by the neurons located there. In a brain with advanced Parkinson's disease, this region appears much paler during autopsy. The dark neurons are gone. These neurons produce a neurotransmitter called dopamine. Dopamine travels from the substantia nigra to a region called the striatum, where it helps enable smooth and coordinated control of movement. As dopamine levels decrease because the neurons producing it die, movement becomes impaired, slower, stiffer, less precise, and increasingly difficult to initiate. What causes these neurons to die is associated with the formation of abnormal protein deposits called Lewy bodies, involving the same alpha-synuclein aggregates discussed in the Lewy body dementia video on this channel. As these Lewy bodies accumulate inside neurons, they interfere with normal cellular function and eventually contribute to neuronal death. Here is the critical point about timing. The brain compensates. As neurons begin dying in the substantia nigra, the remaining neurons work harder and more efficiently to preserve function. Dopamine is utilized more effectively. Alternative pathways are recruited. The brain can hide the loss for years. By the time compensation finally fails, by the time the tremor appears and the diagnosis is established, 60 to 80% of the relevant neurons may already be gone. The disease may have been developing silently for a decade or longer. This is why stage 0, the period before diagnosis, matters much more than most people realize. Stage 0, before diagnosis, is the prodromal phase. Prodromal means preceding the main symptoms. In Parkinson's disease, this phase can begin 10 to 20 years before the first motor symptom appears. And it is not actually symptom-free. It has its own collection of signs, primarily non-motor symptoms, that are now recognized as some of the earliest indicators of the disease. The first is anosmia, the loss or reduction of the sense of smell. This is not simply a cold and not ordinary allergies. It is a persistent or progressive decrease in the ability to detect odors that has no other obvious explanation. Research has found that anosmia occurs in a large proportion of Parkinson's patients and can precede motor symptoms by years. Many people simply attribute it to getting older. Others never mention it to a doctor. The second is constipation, particularly chronic, treatment-resistant constipation that is unusual for the individual and has no obvious dietary explanation. Research has suggested that Parkinson's pathology, including alpha-synuclein aggregates, may begin in the gut before spreading toward the brain through neural pathways. Constipation as an early feature of Parkinson's disease has been documented in numerous large studies. The third is REM sleep behavior disorder. During normal REM sleep, the body becomes temporarily paralyzed. In REM sleep behavior disorder, that paralysis does not function normally. The person may physically act out dreams, talking, shouting, kicking, or sometimes striking out in ways that can injure themselves or a sleeping partner. Research has established that REM sleep behavior disorder can precede the motor symptoms of Parkinson's disease by many years, sometimes by a decade or longer. It is considered one of the stronger early indicators of the condition. The fourth is depression and anxiety that develop without an obvious external explanation. Changes in mood regulation are recognized as early non-motor features and may reflect disruption of dopamine and other neurotransmitter systems that begins well before movement symptoms appear. Do not let stage 0 feel like an abstract concept. These are real symptoms that real people can experience for years before a neurologist connects them with Parkinson's disease. A person with persistent loss of smell, chronic constipation, and a partner who notices that they kick, shout, or move during sleep may be experiencing features associated with the prodromal phase of a condition that will not be diagnosed for another decade. When multiple prodromal features are present, particularly a combination of reduced smell, constipation, and REM sleep behavior disorder, discussing these symptoms with a neurologist can be appropriate and worthwhile. Stage 0 is the disease before it has a name. Stage 1 is the first point at which the condition becomes clinically visible. Stage 1, the earliest clinical stage of Parkinson's disease. Using the Hone and Yahr scale, one of the most widely used staging systems, first published in 1967 and still used clinically, Stage 1 is characterized by symptoms affecting only one side of the body. The tremor, when present, may appear in one hand, one arm, or one leg, rather than both sides. The stiffness and slowness of movement, called bradykinesia, may also remain primarily unilateral. The characteristic resting tremor associated with Parkinson's disease, which often decreases during purposeful movement and returns while the limb is at rest, is the symptom most people recognize. But tremor is absent in a significant portion of Parkinson's diagnoses. Not every person with Parkinson's disease shakes. Other stage 1 changes are often noticed by family members before the person notices them personally. A reduction in arm swing on one side while walking. A subtle change in facial expression, the face becoming less animated or less reactive, known as hypomimia. A softer, quieter voice, known as hypophonia, and handwriting becoming smaller and more cramped, known as micrographia. Daily life during stage 1 is generally maintained. The person can often continue living independently, working, driving, and managing normal routines. The symptoms are genuine and noticeable, especially to someone who knows the individual well, but they usually do not yet create major functional limitations. The critical issue at stage 1 is diagnosis. Because symptoms are mild and occur mainly on one side, people and sometimes doctors may attribute them to musculoskeletal problems, overuse, injury, or normal aging. Studies have found that the time between symptom onset and diagnosis can exceed a year for many patients. That delay matters not because treatment can reverse the existing damage, but because it postpones the creation of a care team, lifestyle planning, and preparation for the increasing demands of stage 2. Stage 1 is one side of the body. Stage 2 is when the disease crosses the midline. Stage 2 means symptoms now affect both sides of the body. The tremor, stiffness, or slowness that was restricted to one side during stage 1 now involves the opposite side as well. Movement becomes slower overall. Tasks that once required 30 minutes may now require 45 or 60. The change is gradual, cumulative, and consistent. Facial expression continues to diminish. The voice may become quieter. People who know the person well may notice that something about their expressiveness has changed. Not their personality, but the physical ability through which their personality is communicated. The face that once laughed easily may now require more effort to animate. Posture also becomes more noticeable during stage 2. A slight forward flexion or modest stoop may appear. Footsteps can become shorter and more shuffling rather than clean and deliberate. Turning around, standing from a chair, and initiating movement after being still can all require greater concentration and effort. Importantly, balance during stage 2 generally remains functional. The person can still recover from a stumble. They can usually continue living independently and handling daily activities, although everything may take longer and require more effort. Non-motor symptoms that appeared during the prodromal phase may become more intense during stage 2. Sleep disruption, constipation, mood changes, cognitive slowing, and reduced processing speed can all continue. These symptoms are often undertreated because appointments tend to focus on motor function, which is visible, measurable, and central to the staging system. For the person living with Parkinson's, the non-motor burden of stage 2 can sometimes feel heavier than the motor burden. Stage 2 still looks like independence. Stage 3 is where that independence begins to come under genuine threat. Stage 3. The defining characteristic of this stage, the clinical feature that separates stage 2 from stage 3, is balance impairment, specifically postural instability. The person can no longer reliably catch themselves after an unexpected loss of balance. Falls begin occurring. They may not happen frequently at first, but they become common enough that falls are now a clinical concern and a daily safety issue. Neurologists assess this with what is known as the pull test. Standing behind the patient, they apply a sudden firm pull backward on the shoulders. A healthy person or someone in stage 1 or 2 usually takes a single step backward to restore balance. A person in stage 3 may take several steps backward or may be unable to correct themselves at all. The automatic postural reflexes that normally protect us are no longer dependable. Falls in Parkinson's disease are not trivial. They are among the major causes of hospitalization and serious injury in people with the condition. The combination of slowed movement, rigidity, and impaired postural reflexes means that when a fall starts, the body may not respond quickly enough to stop it. A hip fracture during stage 3 is not simply an isolated physical injury, it can alter the entire course of care. The person in stage 3 may still be physically independent for many activities and may continue living alone, although the risks are increasing. Driving should be carefully evaluated at this point. Reaction time, spatial awareness, and the ability to respond to unexpected situations can all be affected. For a loved one, stage 3 is the point when home safety modifications become urgent rather than optional. Grab bars, shower seats, removing trip hazards, and adding non-slip surfaces are not premature. They are practical interventions designed to prevent injuries that can accelerate functional decline. Stage 3 can still allow independence. Stage 4 does not. Stage 4, the transition from difficult independence to genuine dependence. During stage 4, the person may still be able to stand and walk, often with a walker or another mobility aid, but living alone is no longer considered safe. The physical demands of daily life have exceeded what the disease allows them to handle without regular assistance. Dressing, bathing, preparing food, and managing medication schedules may all require help. Falls become more frequent and potentially more serious. The non-motor symptoms that were present earlier become significantly more pronounced during stage 4. Sleep disruption can become severe. Constipation may require active medical treatment. Blood pressure regulation can become impaired in a condition called orthostatic hypotension, in which blood pressure drops substantially after standing, causing dizziness and increasing the risk of falling. Pain, fatigue, and anxiety are also common. And during stage 4, cognitive changes become a major clinical concern. This is where families need a clear explanation. Parkinson's disease dementia, the cognitive decline associated with long-standing Parkinson's disease, develops in a substantial proportion of people with the condition. Many people in advanced Parkinson's have some measurable degree of cognitive impairment, and for some, full dementia develops during stage 4 or stage 5. The pattern of cognitive change can differ somewhat from Alzheimer's disease. Attention, processing speed, and visuospatial abilities are often affected. Memory can also become impaired, although it is not always as prominent early on as it is in Alzheimer's disease. Hallucinations, especially visual hallucinations, can occur during stages 4 and 5 and may be profoundly distressing for families who were never warned about them. This is related to the underlying biology. Parkinson's disease dementia and Lewy body dementia involve closely related pathology, including alpha-synuclein aggregates in similar brain regions. For a loved one at stage 4, the same caution regarding certain antipsychotic medications that applies to Lewy body dementia is important here as well. Certain antipsychotic medications used for behavioral symptoms can produce severe, and in some cases life-threatening reactions in people with Parkinson's disease. The medical team treating behavioral symptoms in someone with Parkinson's should know about this risk before an antipsychotic is prescribed. Stage 4 brings the full weight of the disease into everyday life. Stage 5 is the final stage, and it requires the clearest possible understanding before families reach it. Stage 5, the most advanced stage of Parkinson's disease. In stage 5, the person can no longer walk safely and may be wheelchair-bound or bedridden. Every activity of daily living requires substantial assistance from another person. The motor symptoms that began as a unilateral tremor in stage 1 have progressed over the years into near-total motor dependence. Swallowing can become impaired in stage 5, a condition called dysphagia. Food and liquids may enter the airway instead of the esophagus, creating a serious risk of aspiration. Meals may require careful techniques, modified textures, and sometimes thickened liquids. This is similar to the end-stage process discussed in the dementia content on this channel. The underlying mechanism is related in that the brain gradually loses its ability to coordinate increasingly complex muscular sequences. The most demanding functions can fail as neurological control becomes more impaired. Dementia is present in many people who reach stage 5. Hallucinations, confusion, and significant memory impairment may become common. The person may not consistently recognize family members. Verbal communication may become limited. And yet something important remains true here as well. Some responses can survive when almost everything else has been taken away. The response to a familiar voice, the response to touch, the response to music. These are not necessarily imagined. They can reflect the survival of fundamental and deeply rooted neural systems in the brain, systems that may be affected later rather than earlier. Most people with Parkinson's disease do not die directly from the disease itself. They die from its complications. Aspiration pneumonia is a major cause, along with injuries from falls and complications of prolonged immobility. The cause listed on a death certificate may not simply say Parkinson's. The ultimate cause may be the complication created by what Parkinson's has made increasingly difficult or impossible to prevent. An advance directive, the documented statement describing what a person wants for their medical care, should ideally be discussed and completed during Stage 3 or Stage 4, while the person can still participate fully and clearly in those decisions. Stage 5 is not the ideal time to make those choices. It is the time to follow the decisions that were already made. Before we finish, I want to address the cognitive trajectory directly, because it is one of the aspects of Parkinson's disease that families are least clearly prepared for at diagnosis. A substantial proportion of people with Parkinson's disease will develop dementia during the course of their illness. This is not an unusual complication. It is a recognized part of the disease's natural history for many patients. The Parkinson's disease dementia that develops later shares underlying pathology with Lewy body dementia. Both involve alpha-synuclein and Lewy body accumulation in neurons. The distinction between these diagnoses is largely based on timing. If cognitive symptoms appear around the same time as, or within 1 year of, motor symptoms, the diagnosis may be Lewy body dementia. If cognitive symptoms develop more than 1 year after established motor symptoms, the diagnosis is generally Parkinson's disease dementia. The brain pathology is closely related. Families who are not warned about this connection can experience cognitive decline during stages 4 and 5, as though a second disease has suddenly arrived without explanation. In reality, they may be witnessing the later expression of the same neurodegenerative process that contributed to the motor symptoms seen in stage 1. If you are caring for someone with Parkinson's disease and this is the first time you have heard clearly that dementia can become part of the progression, learning about Parkinson's disease dementia before stage 4 makes it urgently relevant, can help families prepare rather than react. Parkinson's disease currently has no cure. What research does support is a group of interventions that can meaningfully improve quality of life and may influence aspects of progression across the stages. Exercise is among the most consistently supported modifiable factors in Parkinson's disease. High-intensity aerobic exercise, balance training, resistance training, and activities such as boxing, dancing, and Tai Chi have all been studied and shown to improve motor symptoms, support function, and potentially benefit cognitive health in people with Parkinson's. This is not simply a gentle suggestion. Multiple randomized controlled trials have demonstrated measurable benefits. Sleep management is also important, particularly when addressing REM sleep behavior disorder and the sleep disturbances that commonly become more significant from stage 2 onward. Better sleep can improve quality of life and may support cognitive function. Social connection and cognitive engagement, themes discussed throughout this channel, may also help build cognitive reserve and support brain resilience in Parkinson's disease, just as they can in other neurodegenerative conditions. The neural redundancy created through an active cognitive life may provide some protection against the functional effects of pathology reaching cognitive regions. These are not cures, they are tools. In a disease where a large proportion of the relevant neurons may already be lost by the time of diagnosis, every tool that helps preserve remaining function matters. One question in the comments before you go. Which stage of Parkinson's disease were you least familiar with before watching this video? And which stage most closely describes the person you are watching this for? Just the number. Stage 0 through stage 5. I read every comment and your answers help shape what this channel covers next. If this video gave someone you love a clearer understanding of what Parkinson's disease can look like over time, share it with them. Share it with the family member who keeps asking what to expect, with the caregiver who is in stage 3 right now and needs to understand stage 4 before reaching it.